We briefly spoke about anemia lab values before, but distinguishing between different types of anemias can be very difficult, and there are several lab values that will be given in your exam questions. These lab values are going to help you make sense of a long pathologic process given in a question stem. Now, it may not be necessary to memorize the exact normal lab values, as they will be provided on your exam. However, it is vital to really understand what high or low values mean. So we'll take just a second to walk through each of these lab values. First is the serum iron, which is only the amount of iron in the serum and is not the total body iron. Why would a patient have low serum iron? Well, this could mean one of two things. Either you don't have enough total body iron to start with, or you could be stockpiling all of your iron in storage, and you aren't letting any out into the serum. This is kind of like what we talked about with anemia of chronic disease. And what can transferrin tell us? Well, transferrin transports iron in the body. It's a good measure of how the body is trying to use available iron, and as we said before, it can be inhibited by hepcidin. We also mentioned ferritin previously, and it is a measure of stored iron. Lastly, percent transferrin saturation is a very simple calculation of the amount of serum iron divided by the total iron binding capacity, or transferrin. Now let's talk about all of our labs in iron deficiency. Try to predict each of these labs. The serum iron would be low. The total iron binding capacity, or transferrin, would be high, as the body is trying to capture and use as much of the iron as it can. The ferritin would be low, as the total body iron is low. Both the serum iron and stored iron are going to be low. And lastly, our percent transferrin saturation is going to be very low. This is because as we've decreased the numerator, which is serum iron, and increased the denominator, which is total iron binding capacity, we have drastically decreased the percent transferrin saturation. What would you predict for the anemia of chronic disease? Well, our serum iron is going to be low, and our total iron binding capacity is going to be low, because as we spoke of before, hepcidin is decreasing both of these values. Our ferritin is going to be high, because our stores of iron are full, but we're not releasing any to keep it away from potential invaders. Our percent transferrin is going to remain the same, because both our serum iron and our TIBC decrease at approximately the same rate. Now let's try our hand at hemochromatosis, which is basically an iron overload state. Our serum iron is going to be high, and our ferritin is going to be high, because we're iron overloaded. Our TIBC is actually going to be low, because our body is not going to want to capture and utilize any more of the iron. At this point, the body will naturally downregulate the transferrin production. And lastly, our percent transferrin saturation is going to be very high, because our serum iron went up, and our total iron binding capacity, the denominator, went down. Lastly, let's have a look at pregnancy or oral contraception use. Serum iron and storage of iron are going to remain stable in these conditions, but these conditions are going to cause our transferrin to increase, and directly because of this, our percent transferrin is going to decrease. So even though our iron levels are normal, there is an apparent reduction in the percent transferrin saturation that can fool you into thinking that the iron is actually low. What is the best way to distinguish iron deficiency from anemia of chronic disease? The answer would be ferritin, or stored iron, and this is because it is the measure of the fundamental difference in these two disease states. I ask this question because it is extremely commonly tested. In iron deficiency, ferritin or stored iron is going to be low, and in anemia of chronic disease, ferritin or stored iron is going to be high. Let's quickly discuss the three types of leukopenias. The three basic types we'll discuss are the neutropenias, meaning by definition, an absolute neutrophil count of less than 1,500 cells per millimeter cubed under microscopic examination. The lymphopenias, meaning an absolute lymphocyte count of less than 1,500 cells per millimeter cubed, or less than 3,000 cells per millimeter cubed in children. And lastly, the eosinopenias, which you don't really need to be concerned about a fixed definition for these eosinophil counts. In your exam, you may see all of these in an aplastic anemia. A neutropenia will specifically be caused by SLE and septic shock. Can you think of a drug that would cause a neutrophilia? Well, interestingly, you may see a neutrophilia, or a high neutrophil count, in a patient taking corticosteroids. Do you know the mechanism here? This is because corticosteroids will decrease the adhesion molecules on the neutrophil, and thus, neutrophils will be unable to migrate out of the vasculature, and a blood draw will show more of them on a WBC differential. By contrast, these steroids will sequester eosinophils outside of the blood and cause apoptosis of lymphocytes, thus decreasing these two counts. All of these actions of corticosteroids will have the desired effect of decreasing inflammation and the immune response. Lymphopenia will be seen in HIV, as this virus targets the CD4 positive cells, DeGeorge syndrome, as T cells are unable to mature, subacute combined immunodeficiency, with its absence of functional T cells, and SLE from multiple mechanisms. Eosinopenia can be specific for both Cushing syndrome as well as corticosteroid use. Now we're ready to talk about heme synthesis and some related pathologies. The porphyrias are generally acquired conditions that will eventually cause a buildup of a particular heme precursor depending on the defect. This can also be mimicked by other conditions because things like lead inhibit specific enzymes in this pathway and results in a similar accumulation of heme precursors that manifests in a disease. This pathway is a pretty good way to help you keep your porphyrias straight. As you can see, glycine and succinyl-CoA combine to form delta aminolevulinic acid, or ALA, via the enzyme delta ALA synthase. This is the rate determining step for all heme synthesis, meaning that hemoglobin production is determined in large part by how effectively this enzyme works and by the abundance of its substrates. This enzyme is negatively regulated by glucose, and the end product of this heme synthesis pathway, heme. This is so that the body does not waste energy producing heme when there's already plenty of heme floating around. So, if heme is low, then ALA synthase activity is high. And if heme is high, then ALA synthase activity is low. Another important point to remember is that this enzyme uses vitamin B6 as a cofactor. As you may recall, sideroblastic anemia is caused by a hereditary delta ALA synthase deficiency. This can be treated with vitamin B6. And now you understand a little more about why. Delta ALA is then converted to porphobilinogen via delta ALA dehydratase. Do you remember what we spoke about that can block delta ALA dehydratase? That would be lead in the condition of lead poisoning. Porphobilinogen is then converted to hydroxymethylbilane via the enzyme porphobilinogen deaminase. This reaction is important because deficiency of the active enzyme leads to the second most common porphyria, acute intermittent porphyria, or AIP. The next important reaction is the conversion of uroporphyrinogen 3 to coproporphyrinogen 3 via the enzyme uroporphyrinogen decarboxylase. Deficiency in this enzyme leads to the most common porphyria, porphyria cutanea tarda, or PCT. And do remember to be aware of the most commons on this exam. PCT presents with its characteristic blistering cutaneous photosensitivity and the substrate to look for in the serum, which would be uroporphyrin. Importantly, uroporphyrin also causes the infamous tea-colored urine. A few more steps, and protoporphyrin joins iron to form heme via the enzyme ferrochelatase. If lead poisoning didn't block all of the heme synthesis at the delta ALA dehydratase step, it also blocks the last step in heme production by inhibiting ferrochelatase. So we talked about the pathophysiology of lead poisoning, acute intermittent porphyria, and porphyrina cutanea tarda, but how do they present? We've discussed a little on the clinical presentations of lead poisoning, but here are a few key situations where if you see them on the boards or in real life, you should think about lead poisoning. These include exposures such as old houses with lead paint, People who work in ammunition production, battery, auto shops, or radiator factories can all have exposures leading to increased lead levels. Also, it is important to know that patients will have high levels of protoporphyrin and delta ALA with lead poisoning. These can be very good serum markers if you suspect this disease. Acute intermittent porphyria can be remembered by the 5 P's: painful abdomen, purple or port wine colored urine, polyneuropathy, psychological disturbances, and precipitation by drugs like barbiturates, alcohol, and starvation. One little tidbit is that porphyria is Greek for purple pigment, and the disease is named for the characteristic urine pigmentation. When we think about treatment, we should first make sure that we understand what the problem is. With AIP, the problem is the buildup of defective hemoglobin precursors that can cause all of the symptomology that we discussed a moment ago. Ultimately, the goal is to prevent hemoglobin precursors from being generated. In this case, the best way to do it would be to block any signaling for hemoglobin to be made in the first place. This is best regulated by delta ALA synthase, which is actually the current target for treatments. Since delta ALA synthase is the rate-limiting enzyme in the pathway, one very useful treatment for AIP is to use the natural regulators of the enzyme to turn it off. This is done by giving heme injections and glucose to inhibit delta ALA synthase. Now that we've discussed lead poisoning, let's turn to iron poisoning. Iron poisoning has a high rate of mortality in children who may accidentally overdose on adult medications that can look like candy to small children. This may be the exact presentation you will find on your Step 1 exam. The mechanism of iron poisoning is peroxidation of membrane lipids that leads to cell death. Symptoms you should be aware of include nausea, vomiting, gastric bleeding, lethargy, and GI obstruction. Treatment includes chelation with either IV deferoxamine or oral deferasirox and dialysis.